Ryan McComack with the PGY7s, and I'm going to be talking about stereotactic magnetic resonance guided laser ablation of periventricular nodular heterotopia. And this was just recently accepted into Annals of Neurology. That's good. So the neocortex is a set of layers in the cerebral cortex that's involved in really higher brain functions.
So how do we get rid of them?
I tried to. There you go. This neocortex is especially expanded within the human brain, with about 90% of the cortex being neocortex and 76% of the weight of the entire brain being neocortex. These are the 6 different layers that we all learned about in medical school, with the molecular layer, the external granular, external pyramidal, internal granular, internal pyramidal, and then the multiform layer. Here you can see the Nissl staining of the actual bodies of the glial cells and neurons, and then the myelin stain that shows the connections between these layers. Here's an example of how a pyramidal neuron that's typically in layers 3, 4, 5, how it can spread and have unipolar long apical dendrites up to the molecular layer, as well as basal dendrites that provide multiple connections between these cells. Even though most of this development occurs without problem, there are several errors that can happen. We've heard about all of these, from lissencephaly with the smooth brain with only four distinct layers, to what we're going to be talking about today with the periventricular heterotopia, where there's an abnormality in radial neuronal migration and then also your radioglial morphology, which leads to basically neurons being stuck and sheets of neurons accumulating at the ventricles under the cortex. And this, like I said, can be shown as either a nodular or a laminar pattern. For the periventricular nodular heterotopia, there's a high seizure rate within these patients, with most of them developing intractable epilepsy. And as I said before, this is an abnormal neuronal migration, which leads to atopic, uncalcified neuronal nodules. And this is because of some genetics that are related to this. There's a female predominance, and with the seizures having an average age of onset at 15, intelligence is usually fairly normal. And then there's also a risk of cardiovascular abnormalities and coagulopathy, like I said, because of that genetic syndrome that's associated with this. Overall, though, despite this being fairly frequent, it's not very well known. The spiking from nodules is common. However, it's unclear, where exactly these seizures are coming from, how this is synchronizing to the overlying cortex, and how this can actually lead to excitation and signals to distinct and sometimes distant regions. So, like all epilepsy talks, we're going to have a patient that we're going to be talking about here. So this is a 36-year-old right-handed lady with onset of her epilepsy at age 16. Her seizures consist of stirring spells with no preceding aura initially. Now she has anxiety before this. Usually she stops talking or reverts to Spanish when these happen. She has several seizures per week and has failed many different anti-epileptic medications. Here is a coronal scan of her of an MRI of her brain. Here you can see this periventricular nodular heterotopia within the ventricle, or just overlying the ventricle. When you look at the EEG, which isn't showing up great here, but you can see that there are spikes that are occurring, basically right here. And these sharp waves are maximal, suggesting a left temporal epileptogenicity of where everything's coming from. She underwent phase 1 evaluation, where she's monitored for several days, and they actually assess and they try to induce seizures. And here again, we found that the seizure was coming again for this left posterior temporal onset at P7. So PBNH, like I said before, it consists of intractable seizures. It often mimics epilepsy from the adjoining or remote cortex. And sometimes there's very subtle MRI findings. So just a single one of those small nodules that can be missed, sometimes even by our radiologists. So what's important next? Look at the family history. Like I said before, with their classic form, 50% have a filament 1 mutation that's an X-linked dominant. However, there's other familial forms that exist. You can also have other malformations that occur. Basically, if you have one problem with neuronal migration, others can happen, including polymicrogyra or hypoplasia. And then, of course, like I said before, there's other comorbidities that can happen with this disease. So exclude anything else and then prove that the seizures are actually coming from the nodule. So there's a lot of non-invasive testing that can be done. In general, this is not really that helpful for PVNH. This patient, like I said, the MEG wasn't very helpful, Neuropsych wasn't very helpful. So what is kind of the next step? And this is really SEEG. So SEEG allows for faster, broader implementation. It allows for deep analysis and it's fairly safe. And it also provides better targeting of kind of what is actually leading to the epilepsy that these patients are suffering. This is an example of how densely we can actually look at and sample different regions of the brain. You can see very high density of electrodes within the cortex here. Back to our patient, here's an example of some of the slices showing these individual electrodes. And here you can see that we have, right here, we have fairly good analysis of this PVNH nodule right by the ventricle. This is an example of what can be seen when you actually look at that nodule independently, and you can see there's high frequency oscillations, which is characteristic of PVNH-induced epilepsy. And when you look at kind of the broader report that's seen with this, you can see there is again these sharp fast waves that occur, and then this leads to then her overall it spreading and her having her habitual seizures. So, like I said, nodules have very little gray matter. They need to be amplified, and these can easily be missed, especially if you don't have high density sampling of the nodules. And this spread can happen very quickly in the tens of milliseconds. So again, it requires a very adept epileptologist of being able to detect this. So PVNH is contributing to your seizures. Now what? This is kind of a big problem that the field has had. This is deep. Sometimes you can have extensive lesional tissue. You really can't do an open resection. Radiofrequency ablation, this is kind of the standard before, which is you do the SEEG, you say this is the area where the seizures are coming from. So then they end up ablating using that, but you're unable to track this in real time. So what are our other options? This is our MRI-guided laser interstitial thermal therapy. So this is using a cooled laser cannula that's inserted stereotactically. The lesion production is done in MRI scanning with continuous MRI thermal mapping. This allows you to see the actual heating of the tissue within the target and then also the structures that are adjacent because, like I said before, this is in usually fairly eloquent areas. And using the Arrhenius equation, you're able to actually use the area under the time temperature curve to actually see as tissue's dying. So here, basically, this range here is kind of the golden window for when we're actually able to kill the cells and not hurt anything else. This actually, you can visualize very well as seen here. This is the combination of a temperature map and damage model in these patients, where we're actually able to see what is the temperature at the site of the laser probe, and then also using the equation as described earlier, the temperature over time to actually look at damage that's happening. This is also very successful at allowing you to have very controlled ablation. This is the big problem, like I said before, with RF and cryo, where this ablation zone is in the range of 5 to 10 millimeters, whereas with laser, you have a very, very minimal transition zone between normal cortex and ablated tissue. Now we're going to go to what we've seen and what we're looking at with the paper. So with this, We looked at the cohort of 760 surgical epilepsy patients. Of these, looking back on them, both prospectively and retrospectively, we found that 52 of them had PVNH. In fact, a lot of those, it was actually not even picked up until the deeper dive went into them to find that they actually had PVNH, because as I said, usually this is fairly minor findings on MRI scans. Of these 52 patients, 39 were treated with laser ablation. And of this, like I said, there's really two different varieties of PVNH localization. One where it's localized in discrete specific areas, others where it's diffuse laminar spread along the ventricle. That's usually associated with the genetic filament disorder. And of these, basically, the big takeaway of this is that PVNH is relatively common, and with about 7% in a surgical epilepsy cohort of all comers. And PVNH is also commonly associated with other lesional etiologies in about 28% of patients. So again, if patients have this disease, it's important to make sure that they don't have other things going on as well. So back to our patient earlier, these are two additional kind of coronal scans. This is in a wire overlay of the brain. The blue is the ventricles. The purple or pink is the actual PVNH. And then the green, you can see the different SEEG electrodes with high density sampling of the nodules. When we go and you can then look at postoperatively, this is at the 3-month post-op scan. You can see there's substantial destruction of the PVNH nodule. And this is actually modeling of our of where we actually ablated the tissue. And you can see we did a very good job. Green is actually showing here if there's any residual PVNH, and there's really no residual. This patient was treated with 3 different lasers with, like I said, over 98% ablation of the PVNH. So this patient, like I said, has a 98.7% ablation of their bilateral PVNH seizure onset zone. Patient now has complete seizure freedom and has stopped their medications, being them now they are at ILAE of 1. And one common comment that people would have is, well, here you put in 3 laser probes, and of course they're going to have issues. She doesn't have any neurologic deficits from this. Here, this is looking at kind of the comment that was earlier, which is there how much actual PVNH needs to be ablated to have good outcomes. So previously it was unknown if these were usually nodular onsets, meaning it was coming from the PVNH, or if it was coming from PVNH and other surrounding tissue, or PVNH in other locations as well. Here, looking at the SEEG data, we were able to find that most patients had a predominantly nodular onset, meaning it was coming only from the PVNH. However, there were several patients that, through a variety of different factors, we were unable to identify only nodular onsets, but nodular and cortical onsets. Interestingly, for this, we found that our percentage ablation was substantially lower in these patients. So is this a chicken or an egg issue? Did we have lower ablation because we had a poor job of actually localizing where the seizure onset zone was coming from? Or is it just that it so happened that these patients had just poor overall ablation of the tissue? Regardless, you can see very clearly that in patients with poor ILAE scores, meaning that they're continuing to have epilepsy, there's a substantially lower ablation percentage of the PVNH seizure onset zone in comparison to patients with higher ablation rates who end up having seizure freedom. And this kind of goes back to the point that we had earlier, and that we kind of believed prospectively that really the critical part of this is high density SEEG sampling of the nodule. And this really helps for identification of where the epilepsy is actually coming from, especially in patients who have fairly widespread disease. From this, we then have a kind of overall model of what we think should happen with PVNH. Traditionally, the workflow is, if the PVNH is even identified, to go and carry out invasive monitoring and SEEG, and then to carry out some sort of an ablation of that PVNH if it's even believed to be the driving force in the patient's epilepsy. Given what we've seen, where in a lot of patients with unilateral and localized PVNH, they're able to have intervention of just that discrete nodule and with excellent seizure freedom rates. Given that, we're proposing that we bypass the low risk, but the risks that are associated with SEEG and go straight to laser ablation of that nodule. You can see that here in kind of this aim here, where if they have unilateral PVNH, they don't have anything else on findings to just go straight to MR-guided laser ablation. And then kind of as expected, if patients have PVNH and other malformations, do an SEEG to confirm, is it PVNH or is it something else? And then for all patients with bilateral disease, because it's usually a higher overall PVNH burden, to make sure that to do a bilateral SEEG and invasive monitoring to see kind of where exactly everything is coming from. So
this is an incredible diagram. I mean, this is a lot of work that you did.
Yeah.
But it seems like 18 of the patients could have avoided SEG. Like the 16 bilateral SEGs that went on to have MR lit of their PVNH. You know, we could say this because the Boston, Australia, but you know, like why did 36 additional surgeries happen if you're just going to laser ablate the lesion? Which is, you know, it's a challenge in epilepsy in general. Everyone went to let's do as many robot cases as possible. But really, I mean, the treatment is exactly the same. The outcome is the same.
The patients had ATLs also, though.
No. So the 16 that went on to just have bilateral lit, right? So those 16 plus those 18 plus those 10, you know, but those didn't get SEG, but although I think they did in this cohort. So 28 really, right? SEGs happen plus SEG removals. That's 56 cases that happened. That outcome was ablate the lesion. So on the pediatric side, we don't do SEG and we go straight to ablation, but it's food for thought when, you know, he's not here. So.
Yeah, so the major reason for SEEG and kind of these contexts, so to kind of take your point of these two patients, the SEEG is important to say, is it MTS or PMG that's actually leading to the epilepsy? You could make the argument and say, well, it's easy, we have a low complication rate, let's just go ahead and do laser ablation from the onset, like you said.
Yeah.
And if they continue to have seizures, then we carry out a invasive workup at that point.
Yeah.
For these with the bilateral SEEG, you know, this is a little bit kind of more complex because they have bilateral disease. So would you then put them through lasers on both sides? And even those, in some patients, they're having really unilateral disease that's causing most of the problems. So for example, like these 4 patients here that have unilateral seizure onset, but they have bilateral imaging findings. You know, would you say, well, they had seizures are only coming from here, you know, from one unilateral side. So let's go ahead and just ablate that. And then again, carry out an additional workup in the future if they can continue to have seizures. All of that is possible. This is more of a, there was concern from the reviewers and kind of everyone else that if we simplified it too much, then then people would lose the, you know, there's other stuff that needs to be accounted for. And in doing so, there was concern that, you know, we are strictly pushing for everyone to get a laser ablation of this, which and we kind of are, but
yeah. No, it's just food for thought. I mean, this is spectacular work. So it definitely drove a research enterprise, right?
Yeah.
That's the other part of it, that every single one of the reviewers is biased.
Yeah.
Because they have their own research enterprise that revolves around SEG. So you can't take that bias out of the equation, unfortunately, including the epileptologists.
Yeah, exactly. So overall, this is a safe, feasible, and highly effective intervention. In focal localized PVNH without other lesions, with the phase 1 or non-invasive studies supporting this, ablation should be considered as a first-line treatment option, even before this invasive monitoring. As our conversation earlier was, this could probably be expanded even more. But you know, this is certainly a discussion in the epilepsy conferences. And when SEEG is needed, you really need high density implantation to help with the localization of the actual seizure onset zone of the PVNH. And with that, I'd like to thank everyone with the comprehensive epilepsy program and everyone helped, especially Dr. Tandon, who helped to really drive this work forward over the course of several years. Thank you, and any questions?
Brian, the invasive SEEG monitoring, does it ever change after you ablate one side? When you do bilateral, is it simultaneous bilateral?
So in about 60% of the patients, we did simultaneous bilateral. So for example, if on the SEEG monitoring, they had onsets from both, we would do both sides at the same time. However, in some cases where we felt where it was predominantly from one side and very minimal from the other side, we would treat one side first. And then if they continue to have seizures corresponding to the other side, we would then treat the other side. But it wouldn't be a SEEG laser one side. If they continue to have seizures, SEEG again, we would use the initial SEEG.
Yeah, what I'm driving at, and I'm interested in the pediatric experience, how does in patients who have bilateral disease, how does ablating one side modify the epileptogenicity of the other side? Or does it? I don't
Probably doesn't change it that
doesn't
much.
change.
But again,
With the whole connectomics thinking, and I know.
So that's a very prescient question because the connectomics of it change over time. So when you're 5 and somebody figures out you have PVNH, you don't have the network that you have when you're 31 and you've been seizing for 26 years and you finally get presented an epilepsy, right? So it's a very prescient question. I've written many grants about like trying to eliminate the 50 steps it takes to get to the point of getting laser ablation. Because not everybody offers SEG, right? So there's this point, but the epileptogenicity of the other side doesn't exist initially. And it's a very, very important point. There is no MTS, these patients when they're younger. The MTS is sometimes a secondary effect of all the seizure. So it's a very good point. And it can't fully be studied because we're not just going to invasively monitor. But many of us are working on sophisticated, non-invasive ways of figuring it.
Yeah, are the success results, are the results better on the first ablated side or the second ablated side? I don't know.
So in periods where we ablate both sides, we usually have planned beforehand to ablate both sides just in a staged fashion. But there are cases where we ablated one side and we said, well, let's just see if they have recurrent seizures. They have recurrent seizures, and then we ablate the other side. So based off of that, to answer your question, they do better with both sides ablated. But that being said, the other point that kind of Dr. Shaw mentioned is these patients can sometimes have very extensive disease. And part of it is identifying the nodule in patients with like a laminar spread where it's along the entire ventricle, identifying where actually should be ablated. And of course, with us, we're ablating as much as we safely can with that probe trajectory. So, that's kind of the other argument that you could have is you could say, well, are you, how accurate is all of this is if the epilepsy is just coming from one particular area and you ablate the entirety of the PVNH. How do you know it's that one area that's actually causing seizures, which is something that we've also had. It's just a kind of feasibility. And if you're already there and you're already ablating and it's safe to ablate, then, just try to get as much of it as you safely can.
You showed the pathology of it in that gross specimen.
Yeah.
How discrete is this pathology or by MRI?
So
a lot of it can be some dependent, isn't it?
Yeah. So here is so this is a fairly, but I would say that there are certainly quite a few, probably all of the diffuse patients that we have. So about, 15 patients, they all would probably look like this if we sectioned their brain.
Great work.
It's phenomenal work. Thank you.